Okay. Okay. Good morning, wherever you're watching us from. My name is Mr.Selfcare, and thank you so much again for tuning in this morning for yet another interactive and very educative show. Alone but not defeated. Alone but not defeated. The journey of radiotherapy. A journey that is full of pain, strength, and hope. If you come from a family that has never had someone go through radiotherapy, count yourself lucky. Radiotherapy is one of the known treatments for different cancers. But people that have gone through this journey have something in common. They all undergo through this journey in silence, alone. Sometimes pain could be not physical, but emotional pain. Only the strong normally complete this journey. But amidst all those challenges, this is a journey they always walk with hope that once it's completed, there is going to be some happiness at the end of that day. Uganda Cancer Institute, located in Mulago, houses the only known government facility or government radiotherapy department that offers this service of radiotherapy. I'm talking about Mulago Radiotherapy Department. On record in the year 2023, this small department handled more than 80,000 patients, of which 2,600 patients were new cases that joined that year, and the rest were patients that are continuing with their cycles. This approximately means this small department handles more than 220 patients a day. Mind you, Uganda now has more than 46 millions. This department, Mulago Radiotherapy Department, was established in the early 1960s and has continuously served the ever-growing population of Uganda. In our studios today, we are hosting a friend of mine that has been part of the healing or treatment journey of so many Ugandans. A very knowledgeable, calm man who has been part of the success story of so many patients. Ladies and gentlemen, let's welcome Mr. Karim Mawerere, from a therapist from Mulago Radiotherapy Department. Mr. Karim, good morning.
Yes, good morning. How are you?
We are very fine. We are so honored to have you with us this morning. And thank you so much for accepting our invitation.
Thank you very much.
Mr. Karim.
Yes.
What exactly do you do, and who are you at the radiotherapy department in Mulago?
All right, to begin with, as I've been introduced, my name is Mawerere Karim. I am a radiation therapist at the Uganda Cancer Institute. Maybe to correct a bit, radiotherapy services are under the Uganda Cancer Institute. They were transferred from Mulago National Referral Hospital in around 2014
Yes.
to the Uganda Cancer Institute in a bid to consolidate cancer care under one institution.
Mm.
So I've been practicing as a radiation therapist in the Uganda Cancer Institute since 2014.
Mm.
And that is my position and that is my responsibility at the Uganda Cancer Institute.
Okay. Um, Mr. Karim, what exactly do you do there? When you say you're a therapist, what does it mean?
Well, radiation therapist is part of the cancer care team.
Yes.
And our main role as radiation therapists is to, you know, cancer is treated by many modalities. One of the many modalities to start with surgery as the main cancer treatment. Then there is chemotherapy, we have immunotherapy, radiotherapy, and other support management procedures that help patients to undergo through the cancer management process. Now, as a radiation therapist, our main role is to deliver radiation. Uh, we call it to the target organs or to the target areas using specialized equipment. That is the principal role of radiation therapist. Otherwise, there are many other roles and many other processes that are carried out before that actual treatment or delivery of radiation to the patient. I don't know whether you meant that we should go through the entire process of radiation therapy, or you wanted to know actually the actual role of radiation therapist or the actual role of radiation therapy in the cancer care.
We are going to get there. Um,
Okay.
that actually takes me back to the next question, um, Mr. Karim. How does um, how does radiotherapy? You said your role you dismiss
You
uh,
deliver,
yes
deliver radiation.
yes. Can I ask Madam Nabatanzi Fatuma to switch on YouTube instead, to go to YouTube and switch on YouTube? I think she keeps logging in from here. So um how does one how does radiotherapy work to treat cancers?
Well, first of all, I think we need to understand what cancer exactly is.
Yes.
Then we shall proceed to see how radiotherapy works. And we shall also, I think, look at the radiation therapy process because it's a process. It's not like any other uh, disease or when of which you are going to hospital, you get the treatment that very day, go back either when you're cured or not. Now, to start with, as we said, the cancer is defined in many ways. But the most recent and broad definition of cancer is that it's a group of over 100 diseases that develop due to uncontrolled proliferation of abnormal cells, subject to natural selection, very important, subject to natural selection with the ability to evade surrounding organs and then spread to distant parts. Now, that definition is very important. Each of the words that has been mentioned in that definition has actually a detailed meaning connecting it to cancer. When we say it is a group of over 100 diseases, we mean cancers have characteristics that are similar. However, cancers of each body part tend to differ from cancers of different body parts. For example, if you take an example of the commonest cancer in Uganda, which is cervical cancer, the characteristics of cervical cancer may differ from the characteristics of endometrial cancer, much as it is the same organ, the uterus. But endometrial cancer differs from cervical cancer and it also differs from uterine sarcoma, both in cytology and management. Wherever
Mm.
the whatever the cytology differs, that means the management is also going to be different. So when we say it's a group of 100 diseases, yes, they are all cancers, but with some slight differences in characteristics and therefore differences in the way they are managed. Now, we say they develop due to uncontrolled proliferation. That's the key point. We have our body cells, designed to divide and die in certain ways. However, when it comes to cancer cells, the way they behave is different from normal cells. Their growth, they tend to proliferate at a higher rate than the normal cells. That's why they are able to form huge masses of cells, which take long to die as compared to normal cells, and therefore they keep on compiling and compiling. Now, one of the most important aspects of cancer as compared to other tumors, because there are many cells in the body that can divide at a higher rate compared to normal cells, but not all of them fall under the category of cancer. Now, cell to qualify to be cancer, it has what we call hallmarks of cancer that have to be seen in those cells in order to classify them as cancers. And one of the most important hallmarks is that these cells have the ability to evade surrounding organs and also spread to distant body parts. That is a typical characteristic of cancer that always has to come out. Otherwise, the public is at times confused and misled. Someone has a tumor somewhere, a swelling somewhere, got someone who is not so much qualified or someone who lacks integrity, and then it may confuse you and dupe you into treating something which is not cancer as cancerous. So I thought it was important to bring out the most current and the most detailed definition of cancer so that the public understands it better. Now, that is that. As we said earlier on, there are several ways of managing cancer, and talked
Yes.
about surgery, radiotherapy, immunotherapy, and many other forms of management of cancer that are supportive to these main therapies, main treatments we know. So now, when we talk about radiation therapy, as you asked, um, uh, as I said, as I mentioned earlier on, it is treatment of cancer mainly, but also it involves managed treatment of some cancerous tumors within the body that tend to behave like cancer. For example, most brain tumors are not cancers, but they are managed as cancers, and they are also referred to radiotherapy and radiation therapy. We have what we call liquids, which are common in ladies, especially when they tend to pierce their ears, those swellings that come with ears, the
Yes. Baby
keloids.
Money.
Also managed, also, yes, they undergo radiation therapy, but they are not cancer. So there are some
Yes.
other uh, tumors and swellings that we manage with radiotherapy, but actually are not cancer. So it is important for someone to understand exactly what they are going through or what should be done before any management, any treatment is given to them.
Okay. So, Dr. Karim, you said that number one, when we talk about cancer treatment, it's not radiotherapy alone. I totally understand you're a therapist, but I also believe that being a person from the same department, you could just help our viewers just understand the little um, difference between there is two things that people normally confuse, that is chemotherapy and radiotherapy, using the simplest words possible. I know you're not a chemotherapist, but can you just help our viewers just understand simplest what chemotherapy means and how does it differ from radiotherapy?
Well, the common denominator there is the word therapy, which means
Yes.
treatment.
Mm.
Now, we With chemotherapy, we are using drugs
Mm.
to treat the cancer. These
Yes.
drugs could be intravenous through the veins, they could
Mm.
be swallowed, they could be
Mm.
through other means, but they are
Mm.
mainly drugs. Now, when we come to radiotherapy, we are using radiation, which is not
Okay.
even visible. We're using invisible radiation to treat
Yes.
the cancers. With the drugs, they are visible. You see it, you can hold it, you can swallow it, you can see it through the cannula and so on. But radiation is invisible, just like
Mm.
uh, any electromagnetic
Mm.
yeah, you know that spectrum, the electromagnetic spectrum.
Yes.
Most of the radiations that are there are not visible, except maybe visible light, which is also visible uh, when it is harvested. Um, yeah, visible light is visible, but I mean, other forms of radiation on the electromagnetic spectrum are not visible. And radiation therapy also falls under that. But on the other side of uh, on the extreme side of the electromagnetic spectrum, of which
Mm.
we all know that we have radio waves, we have the microwaves, infrared, then you come
Mm.
to visible light somewhere in the center. Then on the opposite side, on the right, we have the ultraviolet, X-rays, and gamma rays. So in radiotherapy, our main interest, we normally use the X-rays and
Mm.
gamma rays in the
Mm.
management of cancers. And these are produced by certain equipment, certain instruments like we have the cobalt, which is being phased out as we talk now, and then the linear accelerators that are used to produce the radiations. That is briefly the difference between chemotherapy and radiotherapy. And then the other forms of treatment, like hormonotherapy, they use hormones either to
Mm.
suppress the growth of certain tumors or they introduce hormones within the body to interact the action of other hormones to reduce the
Mm.
way, I mean, the rate at which the tumors are growing. Maybe that is the difference.
Ah.
Otherwise, all of
Mm. Omulabi waffe
uh,
ali eyo leero tugenda kwogeramu ku saayansi naye nsaba tubeere bagumiikiriza tujja bitegeera. Omuntu atategeera radiation zino njagala okuba akafaananyi ka microwave ze tukozesa ewaka nti oteekamu emmere eyo tewali kigikwatako n'ogiteekako ne yeetwala naye ogiggyamu ng'eyokya. Kitegeeza nti waliwo amaanyi n'ennimi z'omuliro ezitalabika ezinteractinga n'emmere eyo ezigifuula eyokya. Kati omusawo bw'ayogera radiations kyetutegeeza ekyo. So to viewers watching us, I was trying to help us understand radiation, that radiations are not seen by our eyes. So just like you put food in a microwave and without seeing anything, it interacts with certain radiation and it heats up. That's the same radiations that we are talking about today. Again, if you're here for the very first time, you're welcome. Feel at home. Put your question in the comment section, and the doctor or not the doctor and Mr. Karim will answer, will respond to them at the end of the program. If you're new and you've not yet subscribed, please subscribe and make this your channel. Every Sunday morning at 7 a.m. and also every Thursday at 7 a.m. we talk about a different healthcare program. The role is to make sure all Ugandans are informed about healthcare such that we take healthcare decisions, but also we learn to support the people in healthcare when they come to your offices, to parliament, to your areas of authority to ask for funds, because we know actually where the funds are going. Dr. Karim, Mr. Karim, can you help us understand the science behind radiotherapy and how these radiations actually destroy or control these cancer cells?
well, before we go to that, it is important to note that these therapies we are talking about are not standalone therapies, but they can
Yes.
be used in combination
Mm.
depending on factors. Depending on factors, uh, you can choose to use chemotherapy alone for certain tumors and for certain
Mm.
reasons. you can combine radiation therapy with chemotherapy. There are some instances where surgery, chemotherapy, and radiotherapy are combined. There are instances where radiation and surgery are used alone. There are instances where you have four. You have surgery, you have chemotherapy, radiotherapy, and then hormone therapy. So depending on a lot of factors, these modalities can be used in combination or alone. Yeah. So to get back to your question of how does radiation therapy work, now contrary to what many people think, because when we talk about radiation therapy, in the local language, the common word used is kukalirira. So
Yes.
it means roasting. We usually translated as roasting.
Mm.
So when someone is referred for radiation therapy, the first thing that comes to their mind is that they are going to be burned. There is heat
Mm.
somewhere, and the others call it masanyalaze. That means we expect some electric shocks somewhere, but
Mm.
all those are myths, and which are not right. So
Mm.
radiation therapy. Uh, First of all, it is important to understand that there are two types of radiations.
Mm.
There's what we call ionizing radiation and then the
Mm.
non-ionizing radiation. Now,
Mm.
non-ionizing radiation is on the other side, on the lower side of the electromagnetic spectrum. These
Mm.
radiations, they are strong, but they don't have ability to remove electrons from their
Mm.
atoms. Now, when you come
Yes.
to the higher energies, which are ionizing, they have the
Mm.
ability to remove electrons from the atoms. And it is from that principle that that we use to treat to treat the cancers. How does
Mm.
it do? Now, it is also important to note that we have two types of radiation therapy. There's what we
Mm.
call external beam radiation therapy and
Mm.
then the therapy. External
Mm.
beam means that radiation is coming from outside the patient
Mm.
towards the patient.
Mm.
And now with brachytherapy, the source of radiation is placed directly or very close to where the
Mm.
tumor is. That
Mm.
means it is in the patient themselves.
Mm.
Now, radiation therapy, radiation acts in two ways. There's what we call the
Mm.
direct action and then the
Mm.
indirect action. With direct
Mm.
action, uh, when radiation enters whichever media it is going through,
Mm.
interacts with a lot of course, with a lot of organs, tissues, and then cells,
Mm.
into some chemical and biological reactions. But the
Mm.
principal target of radiation is the
Mm.
DNA itself. When
Oh.
radiation interact, when radiation interacts with DNA, it
Mm.
either breaks the DNA bonds, the DNA strands,
Mm.
leading to one, cell death,
Mm.
mutations,
Mm.
cell death and mutations generally.
Mm.
So where cell death occurs, that means that cell is gone.
Mm.
Where mutations occur, there can be a possibility of repair,
Mm.
but uh, that is for direct action. With direct action, the DNA, I mean the radiation will act on the DNA, break the
Mm.
DNA bonds, and that cell is no more. Now
Mm.
there's indirect action of radiation where the radiation will act with, first of all, the water molecules, because water is the largest component of cells. So it
Mm.
acts with molecules forming
Mm.
those hydros, a process we do refer to as hydrolysis, leading to
Mm.
formation of free radicals. Now it is
Mm.
these free radicals that will act on the DNA, causing either the breaks in the DNA bonds or causing mutations, which will later lead to cell death. So the cancer does not die by burning or electrification, but it is through interaction of the radiation with the DNA, forming mutations that lead to dysfunctioning of the, either cell death or loss of function and loss of reproductive integrity of the cells. So briefly, that is what happens during, that's how the radiation acts. Now, are we still together?
Yes, 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 yes. We hear you, we get you very well.
Yeah, yeah, yeah. So now these processes, it happens in three processes. One is the physical,
Mm,
where the radiation will impact on the cell.
mm,
The chemical,
mm,
where the radiation will break the bonds
mm,
with the cell or within the DNA, and then
mm,
the biological. The biological phase is the effects, the after effects of the chemical reactions that have
mm,
been brought up by the breakages in the DNA bonds. So briefly,
mm.
that is how radiation works. So in other
Wow.
words, yeah,
Mm,
we've seen physical, the chemical, and the biological. So this biological is the end result.
wow. So again, today we are starting with a little bit of science. I want to thank all the people that are watching in. FIFA referee Liz Nasolo, who is currently in Cameroon for FIFA games. Thank you so much for watching and for passing on the knowledge. Again, if you're watching from the audience and you're wondering how actually cancer is treated by radiotherapy, Mr. Karim has explained that well. So it is not right for you to say, omuntu bamukaliridde oba bamwokyeza. No. The process that are happening actually are very sophisticated. Like I said, sometimes the radiation damage the DNA, that cell dies, and then a few other biological processes actually do happen. Mr. Karim, uh, what are different types of therapies used today? Okay, you've, I think, explained that. You've talked about the external, uh, but again, let me ask again, what are the different types of therapies that are used today? And what are the types of external beam, internal, or systematic radiotherapy?
Um, Systematic radiotherapy. I think the systematic treatment is chemotherapy,
Okay,
because radiotherapy is localized treatment. We
okay.
target where the disease is. It's not the
Mm,
entire body. Though there's a technique we call TBI, which is total
mm,
body irradiation, which targets where we intend to irradiate the entire body, right from
mm,
the head to toe, especially in people who have leukemia, and they are thinking of bone marrow transfer, because you have to
mm,
destroy most of the cancer cell, all the cancer cells, and then
mm,
this patient is new bone marrow is replaced into
mm,
this patient. We don't usually we have not started that process at the Uganda Cancer Institute, though they
mm,
are talking about it of recent. However, most of the radiotherapy that is performed, that's carried out at the moment, is localized.
mm,
Now, the types, as we say, there is what we call external beam and then internal or brachytherapy. With
mm,
external beam, we say the radiation comes from sources that are outside the body,
mm,
from equipment such as the cobalt, cobalt
mm,
60 machines, and then the linear accelerator.
mm,
And then brachytherapy, the source is placed directly um, where the tumor is, and then it releases radiation within the tumor. The choice of which one to use is also depends on a lot of factors, but the most
mm,
important is the tumor size,
mm,
how the tumor is. For large tumors, you can't use brachytherapy, because
mm,
brachytherapy mainly uses what we call the inverse square law.
mm.
with a lot of intensity where the source of radiation is, but there's what we call dose fall off. The rate at which the dose falls off at a distance is very high.
Mm.
For example, if you have a tumor and we place the source of radiation within the tumor, after like 5 millimeters, the
Mm.
intensity between where the source is to this 5 millimeter point
Mm.
may be a difference of 80%. So if
Mm.
your tumor is more than, say, 3 centimeters, you can't use such a modality to treat it. You need a modality that has what we call low dose fall off, whereby the intensity between the actual source of treatment and a few centimeters, like 5 centimeters away, may not be so
Mm.
different, may not be so high. It's within a range of maybe 20%.
Mm.
That's why we employ external radiation,
Mm.
external beam radiotherapy, and tumors which are very small, you can put the source within it. And the advantages of each, the advantages of external beam is that you are able to treat large tumors, as we said.
Mm.
However, it is associated with a lot of dose to areas
Mm.
which are not cancerous, to no tissues.
Mm.
Whereas the advantage of brachytherapy is that you are putting the source of radiation directly in the tumor. And that means there will
Mm.
be less dose, there will be less radiation dose to normal tissues that are surrounding, that are around where the cancer is. However, as we said, there are other factors you need to consider before choosing which exact modality to use during the treatment. And in some instances, they are used in combination. For example, in cervical cancer
Mm.
and cervical cancer mainly, we use both external beam
Mm.
radiation therapy and then the brachytherapy. So the patient undergoes external beam for on average for 5 weeks. That is
Mm.
25 sessions to
Mm.
shrink the tumor to a level that can be managed by the brachytherapy. So when a patient comes in with a large tumor, give external beam, reduce the tumor, then after
Mm.
you cannot continue beyond. It is not common to continue beyond 5 weeks. Why? Because as we said, as you're targeting this tumor, there are some organs around that tumor which are not sick. You don't want to
Mm.
destroy them. You don't want
Mm.
to lose their functionality. The
Mm.
essence of treatment is not mainly is not simply to eradicate the cancer or to eradicate the tumors, but to give
Mm.
the patient a better quality of life.
Mm.
Now, if someone comes in with cancer of the cervix
Mm.
and you aim only at destroying the cancer in the cervix without minding about the organs that are surrounding, yes, you may destroy the cancer, he may become cancer free, but
Mm.
again, this person has lost the functionality. For example, the bladder has
Mm.
lost the functionality of the rectum.
Mm.
So, whereas you have eradicated the cancer, but you've not given this patient a better quality of life. Someone who
Mm.
cannot control, urine, someone who cannot control fecal matter, someone who is
Mm.
incompetent, who has developed incompetence both from the bladder and the rectum. You don't want
Mm.
someone to live with such symptoms for the entire life. So much
Mm.
as we want to destroy the cancer, but the quality of life should be preserved. And that's one of the reasons actually why some modalities are preferred to others during this management. So, so when we treat this patient for 25 sessions, we assume
Mm.
we have reduced the volume of this cancer to a certain degree, certain which can be managed by. But again, we have not compromised the functionality of the organs that are surrounding the region where this cancer is. So we go to the other one, the brachytherapy, which will add more dose because ideally what we call the tumoricidal dose for cervical cancer is about 80 to 90 gray. But you can't deliver
Mm.
80 to 90 gray through external beam because
Mm.
what we call the organs at risk, the organs surrounding that cancer, for example, the bladder and the rectum, can't tolerate a dose of 90. The maximum they
Mm.
can go to is 50 to 60. So after
Mm.
50, you don't want to continue irradiating these organs. So we change to the brachytherapy, which will give the extra 40, 30 or 40 gray without affecting the bladder, the rectum, and the bones that are around the cervix.
Wow. Uh, Thank you so much again to our viewers for watching. Doctors clearly explained some of the factors they would consider before either choosing to use an external or an internal source. Some of them being the location of the tumor, the size, and also other factors like what are the surrounding organs, their capacity to handle less or higher radiations, and also other factors like he has said. Again, he has said that it is not a must that one must choose which type of therapy. Sometimes some patient will use chemotherapy and radiotherapy. Some patient will use hormonal and chemo and radiotherapy. Some other patient will do surgery, they will do chemo, they will do hormonal, and they will do all those on. So really what you're going to have is dependent on so many factors. Like again, we always say here, early detection gives chance to these therapists and the oncologists and people handling this cancer to have a variety of therapies to apply on you. But normally when we go late, sometimes beyond certain stages, they only have a few options to apply for you. Again, like always tell everyone here, early detection of diseases is one reason we wake up every Sunday morning to make sure we teach you about diseases such that you can clearly tell when you're not fine, such that you get early screening, early diagnosis, and then early treatment. Mr. Karim, can you walk us through what exactly happens during a typical radiotherapy session from preparation to treatment? When a
Okay,
patient
now,
X comes, how do we prepare them up the treatment room?
okay. Well, thank you very much. So, actually, before the actual treatment starts, I will
Yes.
take you through what happens in a typical radiotherapy department.
Okay.
So when a patient is referred to the department, the first encounter is with what we call a radiation oncologist.
Mm.
Now, these are specialists who are trained to in management of cancer using radiation. Now,
Yes.
radiation and chemotherapy. So
Mm.
what happens is that one, the patient's details have to be reviewed.
Mm.
The confirmation that it is a cancer. There should also be confirmation that this cancer can be managed by radiation.
Mm.
If there is no benefit for radiation, the patient is referred back to whoever has referred the patient to the department.
Mm.
However, after assessing, and also there should be confirmation that the patient is fit for radiotherapy, because there are certain factors they use to determine whether the patient will benefit from the radiation therapy or not.
Mm.
Some of these factors are related to the tumor itself. For example, the stage of the tumor. Some stages are better handled with other modalities like surgery, chemotherapy, or with a combination. Two, the site, where is the tumor?
Mm.
Some tumors are best handled by other modalities, and others better with radiation therapy or a combination. Then
Mm.
we have the size of the tumor itself.
Mm.
If you come in with a tumor and maybe we realize radiotherapy cannot or may not be so useful for that particular size, we can be referred back for review and
Mm.
reviewed by other oncologists who are not radiation oncologists. Think of other modalities. For example, as we mentioned, if a tumor is too huge and we know that this
Mm.
tumor is sensitive to chemotherapy, it is better to refer the patient back for chemotherapy to reduce the tumor, to shrink it to a certain level, then refer the patient back to radiotherapy and we continue.
Mm.
Radiosensitivity. Some tumors are more sensitive to radiation therapy. Others, like sarcomas, are less sensitive. And through a multidisciplinary team, we try to discuss whether this patient will benefit from radiotherapy or other therapies first, then referred for. But however, if the patient passes all those tests and we realize the tumor is radiosensitive, it can be treated with radiotherapy, the patient is fit for radiation therapy, then this patient is booked for what we call simulation. Now, it
Mm.
is under simulation that the patient is sort of coached through coached about what to go through during radiation therapy. As the
Mm.
word stands, simulation, it is imitating what
Mm.
will happen. And if anybody has ever had a patient who has been referred to radiation therapy, you'll be familiar with words like CT planning. CT
Mm.
planning is sort of simulation of what will
Mm.
actually happen. Now, the patient, first of all, is explained. We explain the patient the whole process, the do's and the don'ts during radiation therapy.
Mm.
We try to position this patient on the city coach or on the city coach the same
Mm.
way as the patient will be positioned during radiation therapy. There's
Mm.
what we call immobilization devices that help us to make sure this patient maintains a stable position. First of all,
Mm.
the same position every time they come for treatment, a comfortable position,
Mm.
and stable position. Because when the patient is not comfortable, their chances of movement naturally
Yes.
want to make you comfortable. So we
Yes.
try to use some devices to make sure this patient, first of all, is comfortable, is in a position that can be reproduced, and is a position and is in a position and is in a position is not able to make movements during the simulation and during treatment. So that happens during simulation, and then during simulation we acquire CT images that we use for treatment planning to plan how this patient will be treated. Now, sometimes people are confused because they have gone through CT, they expect you to give them results. They've asked for results. You have done a CT, where are my results? But during this particular process, there are no results we offer a patient. But the images that are acquired during CT are used for planning how the patient will be treated, to determine how the radiation beams will go through the patient, the direction of the beams, the dose to each organ, the dose first of all to our target, which is the cancer, and then we determine which dose, or we find out which organs will receive what dose. Because as I mentioned earlier, you don't want to exceed the tolerance of given organs. You don't want, because when you exceed a particular normal organ can tolerate, that means you are not improving the quality of the patient. You are simply looking at destroying the cancer cells, but you're not looking at the patient as a whole. So that happens during simulation. Then after simulation, of course, there's a consent that is supposed to be signed. For any medical intervention, that there should be consent, and patients are given chance at that particular moment. If they have any questions about whatever process they are going through, they ask. Now, we also coach patients on what preparations they have to undergo before they come for treatment. For example, if you are treating cancer of the prostate, we ask our patients um, to empty their bowels, the bladder and the rectum, uh, before coming for the simulation. And the same thing happens during treatment. There are reasons for that. And we also, after asking them to empty their bladder and the bowel, we give them some water to drink. 500 mils is our standard. Um, 500 mils of water to drink 10 to 15 minutes before the treatment starts. The essence, as we said, um, these immobilization devices and these preparations are aimed at making sure that the patient position is the same every time they come for treatment. Why? We want to aim with the new technologies, the cities, with the new technologies, with the linear accelerators, they have a component. Uh, their main advantage is precision and accuracy. Precision to the tumor, accuracy. We don't want to go actually. We don't want to go 5 millimeters from to treat 5 millimeters away from our target. So we give these give an example of prostate cancer. You know, the prostate is a midline organ. Above the prostate, we have the cervix. Sorry. We have the bladder, and below the prostate, we have the rectum. Now, the position of the prostate is at times determined by how full or how empty the bladder and the rectum are. If they are very full, the prostate assumes a different position. If the rectum and bladder are empty, it assumes a different position. So now that we don't want that discrepancy during treatment. So we want the bladder to have a specific volume of urine every time the patient comes for treatment. So that's why we tell them first empty, so that we are sure there is nothing. Then we give you 500 mils of water, so that we are sure there is 500 mils of water, which is going to hold this prostate at a particular position every time they come for treatment. Because that is what we plan during the simulation, the same thing. So the planners is what we call a TPS, because these most of these treatments, these plans are computer generated. You feed in information, and then computer will generate a treatment plan. So that's the treatment plan you send to the treatment equipment. So the patient comes in, in that time the patient comes is the bladder is in that same position, the bowels are in the same position, the bladder is in the same position, the prostate and all other organs. So that's why we use immobilization devices to ensure that the position is the same and these other instructions. So we appeal to our patients, whichever instruction you are given, please try to
Mm.
adhere. There are reasons, scientific reasons behind those instructions.
Mm.
So that is simulation. Now,
Yes.
on the typical day of treatment,
Mm.
what you went through during simulation is what we
Yeah.
expect to go through during treatment. So when the
Okay.
patient comes in, of course, we
Mm.
know the instructions they got from the other side, and the the radiation therapist in the simulation room, the CT room, we note
Mm.
these will note all these instructions in the
Mm.
patient is, and these instructions are displayed in the treatment room whenever a patient enters. Just look at
Mm.
the screen, then you know what how to instruct the patient, and that
Mm.
is all. So the typical treatment is usually something like 10 to 15 minutes, a typical session
Okay.
of radiation therapy.
Okay.
However, it does not mean that those entire 10 to 15 minutes you are under radiation. No.
Mm.
Radiation may be on for a maximum of 2 minutes. However, the
Okay.
other minutes, the other time is used in what we call patient setup, positioning the
Mm.
patient in the right position, following the instructions that were given during the simulation, as we said,
Mm.
talking with the patient, reassurance of the patient, and then there's
Mm.
what we call imaging. Because when the patient comes in the morning, you lay the patient on the bed in the same position that, as we said, that was used during simulation.
Mm.
However, you can't be 100% sure that you are in that very position, much as you try to apply every instruction that was written by the simulating radiation therapist. However, you go
Mm.
ahead to imaging. The new equipment we have right now, you do uh, imaging while the patient is in that position to confirm that that is the actual position using
Mm.
certain landmarks. It's a CT scan or an
Yeah.
X-ray. Take an
Mm.
X-ray,
Mm.
compare what was acquired during simulation and treatment planning. Then you compare
Mm.
if it is you look at it and you say it is the same position, you continue, you go ahead and treat. If it is not, you adjust. Because as we say, the aim is to deliver a dose as high as possible to that tumor, but again, we want to minimize those the areas that are not sick, but they are close to the cancerous region.
Okay. Thank you so much, Mr. Karim. Actually, you've answered my next question that I was going to ask. How long do normally people take when they go in for therapy? You said it will depend. Some people will go for 8, some people will go for the 2 minutes, depending on the type of tumor that we are treating, the location, and maybe the prescribed dose by the oncologist. So again, for someone watching, if you're someone that has undergone through this radiotherapy journey, feel free to go into the comment section and actually tell us what surprised you most in the processes that Mr. Karim and the team normally tell us to go through. Mr. Karim, you've talked about targeting the main tumor and also limiting the dose to as close as possible to the tumor. That means if the dose goes beyond, we could be having a side effect. What are the most common side effects that patients normally experience during therapy, radiotherapy?
Okay, now um, the side effects, there are some general side effects,
Yes.
and then some, most of them are site specific. And these
Mm,
side effects can be acute or they
mm,
come at a stage. Acute meaning that they can appear during the treatment sessions,
mm,
while others come like 3 months or more after the treatment. Now,
mm.
the, some of the general side effects that patients experience during treatment, there's what we call skin discoloration.
Mm.
The skin loses its natural color
Oh, yeah.
and becomes so dry,
Mm,
uh, then it becomes wet, and in
mm,
adverse conditions, they may develop wounds around the treatment site. If you
mm.
have ever gone through Cancer Institute, you'll experience this. And
Mm.
this is where I think the local word of career care comes into play.
Okukalirira.
Yes,
Yes.
because ideally wounds around the region of treatment,
Yes.
but that is a side
Mm,
effect of treatment because the skin first of all becomes very dry in the
mm,
beginning, then to become
mm,
wet, and when
mm,
treatment continues in adverse situations, you actually develop actual wounds.
mm,
Some people, the area of treatment just becomes darker than normal. You look at your skin and
mm,
there's a patch around where the radiation portal is. So
mm,
that is a common side effect because this radiation is going through the skin. The skin is very sensitive. It's one of the
mm,
most sensitive radiosensitive organs we have,
mm.
the skin and mucosa. Why? Because these have uh, the rate of cell division, the rate of
Mm,
proliferation of the skin and mucosa are very high. And
mm,
there is there's a certain law that says that the radiosensitivity of a given organ
mm,
is directly proportional to the rate of cell division or the
mm,
rate of proliferation. So cells that
mm,
divide very fast have a highly radiosensitive, and those that divide at a very low rate have a low sensitivity to
sensitivity.
radiation.
Mm,
So that's why for most patients who are undergoing treatment, you will see some black patch around where the radiation has passed. So that is a
mm,
common one of the genocide effects. Then the other one is fatigue.
mm,
The fatigue, because cells are
mm,
being destroyed within the body, and sometimes the replenishment is not as high as the
mm,
loss of cells. So they tend to get a lot of fatigue, and also
mm,
psychologically. I mean, you have to wake up every morning and walk a long distance to the hospital. It's going to be like that for the next 5 or 6 weeks. So the stress and so on, all those lead to fatigue, and
mm,
the it goes down. Even loss of immunity is another genocide effect
mm,
because red blood cells are also, I mean, white blood cells are also very sensitive to radiation. So
Mm.
there's a tendency of immunity going
Mm.
down. Yes.
Going down. Mm.
So we've talked about skin, fatigue,
Yes.
immunity. Are some
Yes.
of the general side effects that our patient, anemia, yes, even
Mm.
anemia, many times it's one of the common side effects, general side effects, loss of
Mm.
appetite. Most of our patients, if you interact with them, they lose a lot of appetite. They lose appetite actually during the
Mm.
time they are under radiation. Now, as we said, those are the general. Some are site specific, depending on where you are
Mm.
treating. For example,
Mm.
if you are treating the region of the head and neck,
Mm.
um, there's a possibility of one oral mucositis wounds within the mouth, as I've
Mm.
mentioned earlier. That
Mm.
mucosa is also sensitive. So after like 2 weeks, patients start complaining of wounds within the mouth,
Mm.
and of course uh, that comes with other associated side effects like
Mm.
um, people don't want to eat. Of course,
Mm.
there is also loss of taste.
Mm.
Now, there are wounds within the mouth, the
Mm.
tongue has lost taste. There's
Mm.
also loss of smell.
Mm.
They will complain that I can't smell anything recently
Mm.
during treatment. There's esophagitis,
Mm.
the inflammation of esophagus,
Mm.
and some other diverse side effects. I mean, less side effects like xerostomia and so on and so forth. Tooth decay
Mm.
can also happen if you're treating the region around the neck and head. And yeah, other late side effects, but we are mainly interested in those that will happen during treatment because those impact on the management. Because if someone is
Mm.
not eating, is not swallowing, there is no
Mm.
taste, smell,
Mm.
definitely they will lose a lot of weight. And if you
Okay.
lose weight, yeah, your post
Mm.
weight is down. It impacts on how we manage that patient because sometimes we are forced to have breaks within the treatment, which is not so good. We don't encourage it.
Mm.
We encourage breaks within, but when the side effects are severe, there can be
Mm.
one week break. But this should not come from the patient. It
Mm.
should come from the medical team. They will assess
Mm.
you. Okay, we have given you a break of maybe 1 week. Come
Mm.
back after reassess. Then, if they are still fit to continue, they can continue. But we compensate
Mm.
for that somewhere. But if you just
Okay.
disappear, there is no way you can, it becomes very difficult for us to compensate for loss of time. Because there's
Yeah.
a specific through which this radiation should be given.
Mm.
Because it should be a maximum of 6 weeks. After
Okay.
6 weeks, there's what we call tumor doubling time. The rate at which, when you are treating the tumor, the cancer cells, they also try to fight
Mm.
back. They
Mm.
try
To increase the rate at which they divide. Okay. So again, we are still having a discussion with uh, one of our very own, that is Mr. Karim. And if you've just joined us at this time, thank you so much for keeping it here. We're having a very wonderful discussion. Like we all know, this month we've been handling different types of cancers. We looked at breast cancer, cervical cancer, and prostate. And we really felt it important to look also at the radiotherapy, because after you're positively diagnosed with these cancers, normally the next stage is to go for therapy and look at how these cancers can be managed. And he has explained so well so far. He said we can have chemotherapy, that's where they use drugs. We can have radiotherapy, that's where they use radiations. they can have surgeries, which have been explained in the previous actual discussions by different experts. We can have hormonal therapy, and then these can be external to the body or internal. External is where they put you into a machine and radiation is coming from out, but it can also be internal where they put the source close to the point. So he said everything totally depends on everything totally depends on the stage and also the type of cancer that they are treating. I think we've lost him due to network, but he should be back. Okay. Yes, Doc. Mr. Karim, you're welcome again.
Oh, thank you. I disappeared.
It's okay. It's all good. So it takes us back
we were still talking about
you were concluding on the side effects. And actually, this goes back to the question that someone has asked me here. Can you hear me? I think, Mr. Karim, can you hear me? Mr. Karim, can you hear me?
Yes, please.
Okay. So someone is asking, now that you know these side effects, how do you prepare these patients? How do you prepare them for the side effects they are about to receive? And what are some of the tips that actually patients can use to make sure they don't over suffer from these side effects? Okay. So yes, Mr. Karim.
Yes, please. I don't know what's happening really.
I think someone is either calling your phone or is disturbing your internet now. Tell Madam to first go. Okay, so can you hear me now?
I can hear you well.
Okay, so the question is, what tips do you normally give to your patients to make sure they don't over suffer from the side effects?
When there's some two very important side effects you've not mentioned, I beg to mention them.
Yes, please.
So especially when you're treating around the pelvis and abdomen, almost 90% of our patients develop nausea and diarrhea. Then cystitis, and some rectal symptoms and loss of appetite, as we mentioned. It's very important. Whoever is taking care of these patients should note whenever there's diarrhea, vomiting, nausea, and cystitis. Please, the first one, there are a lot of first of all, as we mentioned, that during simulation or before simulation, these patients undergo counseling, and they are prepared for what they will be going through. And during these counseling sessions, we try to tell them how they care about themselves during treatment. One, we encourage our patients to have a healthy diet during and after treatment. A diet full of proteins, carbohydrates, and vitamins, and to have a lot of foods that rich in iron.
Okay. Network is okay. Proceed.
I think it's just an internet issue. No one is disturbing my phone.
Yes, it's internet. Definitely, yes.
Yeah. So
yes, you can proceed. Yes.
Yeah, there is a there's a misconception among
Mm,
us, either the public or our patients, that there are certain foods you're not supposed to eat during radiation therapy, or when you have cancer.
mm,
And we tell our patients that there is no food you are prohibited from eating. Eat
mm,
everything. Some people will tell you when you have cancer, you are not supposed to take sugar. You're not supposed to eat meat,
mm,
and a lot of other myths surrounding cancer. But we encourage our patients to eat each and every type of food they come
mm,
across, for as long as they have the appetite for that particular food, except
mm,
where you have other comorbidities. Maybe you are diabetic and you are advised not to take certain foods. That's different. However, if you don't have any other comorbidities, please
mm,
enjoy your meat, have your milk, have your sugar. Though we encourage natural sugars like
mm,
honey and sugar canes and so on. But where you cannot afford that, there is no food you are prohibited from eating because of a cancer. So, health diet rich in proteins, carbohydrates, and vitamins, and
mm,
iron giving foods. Two, fatigue is encountered by physical exercise, physical
mm,
activity.
mm,
Because you have the cancer, because you are sick, it does not mean
mm,
that, after treatment, go back in your bed, lie there until the next morning. No. For as long as you can make some exercise, you can move, you can walk around, you can go to the market, you can do your work. For those who don't have any symptoms, because we have patients who are undergoing treatment, but they don't have any symptoms. They don't have pain, they are not bleeding, they are physically fit. Continue with your daily routine. Come for
mm,
your treatment, go for work. Come back in the following morning, get your treatment, go for work. So being physically active helps to, one, your psychology, to improve on your emotional well-being, and it also helps to do to deal with the fatigue that
mm,
is associated with this treatment. Then we encourage our patients to avoid, as we said, where the radiation portal is, where the radiation is passing. We don't
mm,
encourage you. We discourage our patients from using any type of detergent or lotions
mm,
within that area. So take your bath normally. And there's another thing here, misconception that our patients have, that when you're undergoing radiation, since in some local languages it's termed as masanyalaze. They
mm,
say, oh, you mix masanyalaze with water, so you don't bathe at all for the entire 5 weeks and so on. It
yeah,
is wrong. Good hygiene is advocated for during this process. Take
mm,
your baths, but we usually tell you, encourage them to how to use lukewarm water, not too
mm,
cold, not hot, lukewarm, and but
mm,
not to apply detergents and lotions at the treatment site, because some of
mm,
these have alcoholic contents, and they tend to make the skin so soft, and then
mm,
wounds will develop within a short period after treatment. So for those patients whom we are treating the regions around the head and neck, we encourage
mm,
good oral hygiene, and we sometimes give them advice to use warm water with salt
mm,
to rinse the mouth after every 6 hours. Have some warm water with salt in it to rinse the mouth.
mm,
Like that. So good oral hygiene is very important, especially if you're treating the cancer that's around the neck or the head.
mm,
So the other advice we tend to give our patients is to avoid exposing the area that is treated under very hot sun. So
mm,
this of sunbathing and so on, you can, you know, we can postpone until you are done with treatment. Also, having very tight clothing around the treatment area is discouraged, because that
mm,
skin is softer than the rest of the skin. So when you have tight clothing around that, you're increasing the chances of developing wounds. The other thing is that when you're undergoing treatment around an area which is hairy, or an area
mm.
which is supposed to shave, please postpone on the shaving in that region until you're
Oh,
done. Until you're done with the treatment, we encourage you to come after you to start. On the first day you come, shave, and but leave it for the entire treatment period. Don't tamper
mm,
with it. But also, they will develop no hair that around. It is not it's unlikely that hair will develop there, because if it is, even if we found it there, one of the side effects associated with radiation therapy is alopecia. The hair
Mm,
will go off. So
mm,
sometimes when we're going through the cancers, you find people with funny haircuts, those who are being treated for head and neck. Those
mm,
it is the radiation which is responsible for such haircuts. So it's
mm,
not siba malala, it's a
mm,
side effect associated. And it's not bad. So if you
mm,
see it, don't run away. Oh, my hair is gone. I came when I had my beautiful hair. Now it is gone. No. Usually after treatment, it comes back within a month or two. The hair regrows. So there should be no worry when you see your hair falling off. Now, for
yes.
patients who are being treated for cervical cancer,
Mm,
those who have no who are not having a lot of pain and the bleeding is not too much, we encourage them to continue with their sexual activities with their husbands. As
okay.
yes, it
Mm,
contrary to what most people think, that when you're undergoing radiotherapy or when cancer treatment, there's no sex at all. No, we encourage them to have sexual intercourse with their husbands to
mm,
avoid the side effects of radiotherapy, which is stenosis. Because if you don't have this exercise during this period, there's a
mm,
likelihood of having stenosis. Your private part will reduce completely in size and become, you go back like a young girl. But however, for those who are not having husbands,
mm,
we also give them advice. We tell them to get some candles of a reasonable size, of course, have a lubricant, okay, have a condom and a lubricant, and we carry them to be using it like something like twice a week
mm,
for 5 minutes twice a week, so that we avoid the less side effect of stenosis. Because we've seen people coming back after some time and they say, I cannot, I mean, my thing has reduced to a size which I don't understand. It's
wow.
because during radiation therapy, they didn't. So if your husband is also scared, because some people think that when you have intercourse with someone with cervical cancer, you develop penile cancer, but which is of course wrong. They are
Wow.
not in any way related. So
More
those are
reason,
some of
yeah.
some
More
of the
reason,
advice.
more reason we wake up every Sunday morning to be here. That I also didn't know. You see, so if you're lady and you're going through cervical cancer, radiotherapy, sexual activities are encouraged. Dr. Msawa said, if not, your central government may reduce and you become like a baby. I thank God this uh, process is highly guarded by ethical measures. Otherwise, we would have now women coming back, coming because they want to reduce on certain things. But because of the ethics, I think we cannot have people who come for cosmetic reasons. If they feel they are big, now they want to tighten because of what we know. Doctor, you've
Yes,
talked
please.
about simulation.
Yes.
And you said in this simulation process, we explain all this to the patient. I can
Mm,
imagine a poor patient coming from Katente, Nkokonjiro, where I come from, and you tell them, oh, you see, you may lose all your hair, your skin may turn, you may have wounds in the mouth, and all that, depending on type of cancer they are treating.
mm.
And me, I'm imagining this patient not coming back because of the fear for side effects. How mentally do you prepare their body, their minds, and emotionally, how do you handle them that they don't get scared of the side effects that you've explained to them, that they actually come back to start treatments like they always do? Because each time I've visited the radiotherapy department, I've always met thousands of people there. That means there is a way you prepare them mentally to make sure they actually turn up for treatment. Because we've seen people that just refuse to take tablets and they say, oh, I'm not taking these tablets because doctor said it is going to make me a little dizzy. But now we are talking about advanced side effects. How do you mentally prepare this patient that actually they end up taking up these treatments, these therapies?
As I mentioned, before any radiotherapy, those counseling sessions are there. And
Okay.
usually we encourage uh, these patients to be or to come with some at least some family member
Mm.
as yeah, to give some support. But
Yes.
some of the types of counseling we have by cancer survivors,
Okay.
we incorporate them into the system. They come and give talks to give
Mm.
encouragement and show these people
Mm.
that they have through the process,
Mm.
they have gone through it, and they are here still alive with no
Mm.
complications at all, always slight complications. So
Mm.
they tend to benefit a lot from people who have gone through the processes.
Mm.
However, what you mentioned is very true. Some people
Mm.
come, we explain everything to them,
Mm.
and they never come back because of misconceptions that they get from
Mm.
people who are not qualified or people who are not within this field. Many
Mm.
of them, unfortunately, these patients who tend to appear will come back after, on average, after 2 years.
Mm.
They still come back with either with disease progression or still at
Mm.
the same stage for those who are lucky. And now this becomes a problem. You came when you are in a state that is treatable and curable. You
Mm.
disappeared and come back when you are in a stage that we are just going to palliate. We are only treating symptoms that we are sure we are not going to cure this disease. So I think the is partly we are to blame because there is not much information outside for
Mm.
about these treatments and radiotherapy and what is associated with radiotherapy, but
Mm.
also people who have no or negative information about radiotherapy have also played a big role in
Mm.
discouraging people from coming for radiation. But we do as much as we can to prepare them. We
Mm.
engage actually during the counseling sessions. It is also encouraged to involve even religious leaders. We have religious leaders, we have
Mm.
family members, we have a
Mm.
group that specialized in counseling. So though you cannot get 100%, response, but the
Mm.
majority try to respond. And
Okay. Mr. Karim, as we're about to conclude our discussion. Of course, there are so many myths that people say about safety. Many people say, "Oh, the radiation is going to burn my skin, so I'm not safe." Now, apart from that, which so many people call radiation agenda kaliro muntu, what are some other myths and false information have you had your patients discuss with you about radiotherapy?
yeah, apart from those we mentioned,
Yeah.
people have a misconception that when you go for radiotherapy,
Mm.
your chances of surviving are reduced. Okay,
Mm.
first of all, they tell you, for those who are not so radical, they will tell you that your lifespan is decreased.
Mm.
Of course, nobody has, information about the lifespan of an individual. So you cannot say because so and so went through radiation, therefore their lifespan is reduced. Much as there can be science of maybe um, uh, developing secondary malignancies in a later stage after maybe 20 how many years, but there is no scientific evidence to that. But just
Mm.
coming out and say, oh, since whoever has gone through radiation, their lifespan is reduced, really is totally unacceptable. Your
Mm.
lifespan would have been as it was,
Yeah.
since we even know how long you are going to live. So there's no association between the two. Then the
Mm.
other one, those who are more radical, will tell you when you go through radiation, you have called death for yourself. But how it comes about is that most of our cases, we get a lot of cases with advanced disease,
Mm.
and
Mm.
our aim for radiotherapy here becomes palliative, maybe to
Mm.
reduce
Mm.
pain, maybe to stop the bleeding, simply to
Mm.
palliate even symptom that the patient has presented with. So what
Mm.
happens that these patients who have come with this advanced disease,
Mm.
definitely overall their lifespan is short. So when
Mm.
they go through radiotherapy and then thereafter they live for a short period, people try to associate their death to what treatment to the treatment they have undergone. You see, our patient was okay, he had the pain, he was bleeding, but he was still alive. But immediately he
mm,
went through radiation therapy, he lived for only 3 weeks and died. So
mm,
they seem to associate the two, not knowing that by the time they brought their patient for this particular treatment,
mm,
already it was overdue. There's nothing we could do. So radiation therapy is not a death sentence. And the
mm,
same thing is associated with cancer. Whoever develops cancer, they know they have now signed their death certificate, which is not
mm,
true. Cancer is treatable, it is curable, depending on the on other factors that are surrounding it. So that those are some of the myths. People say cancer is inoperable.
mm,
If you have cancer and you go for an operation, the rate of
mm,
of division will increase, and therefore your lifespan will also decrease, which is also a myth, which
mm,
is actually not a myth, totally wrong. But because of the factors, because of what I've explained earlier, people come in late stage.
mm.
So when you try to give any treatment modality they go through and eventually they die, people try to associate their death with that particular treatment modality they have undergone. So some myths I've mentioned, people say when you are during radiation you should not bathe. I've talked about that. Others call it burns, you'll be shocked, electrocuted, and so on and so forth. And then there are things that people tend to assume that every swelling they have on their body is a cancer. We've already mentioned that at the beginning. Not every swelling is a cancer, but you put the qualified medical personnel, they take your samples to the lab, and they give you the appropriate information and appropriate treatment. Then
Uh,
the other thing also, these
mm.
things of don't eat this, don't eat this. No, it has no, there's no association between not eating any particular food with either cure of cancer or progression of cancer.
Okay. Um, Thank you so much. And my very last interactive question here is I was in South Africa during COVID, that is the year 2020, and there was advancement in terms of nuclear medicine, other therapy, especially for prostate cancer using PSMA. In Mulago and under the Mulago Radiotherapy Department or Uganda Cancer Institute as a whole, what are some of innovations and technologies that are in pipeline or that are being implemented to make sure that actually we make these therapies more effective? That is if you're in capacity to speak about that.
Well, before 2017, no, before 2019,
Yeah.
we were using we only had cobalt 60 machines,
Yes.
and we could only afford, there are different treatment delivery techniques for radiation
Mm.
therapy. We have
Yes.
2D, 3D, IMRT, VMAT, SBRT, TBI, and many proton therapy. There are many,
Mm.
many more. But before 2019, we only had cobalt machine, and we were
Mm.
only able to deliver treatment using the 2D techniques.
Yeah.
Uh, at the start of 2020, we acquired our first linear accelerator.
Mm.
True Beam is an American-made equipment. I think it's
Mm.
one of the top advanced machines on the market as we speak. I think
Mm.
there are 3 countries in Africa that have True Beam machines: South Africa,
Mm.
Egypt, then Uganda. So in
And no one of
2020, we
and no one will speak about that we have actually
got,
one of the best machine when it comes to that technology, the one that actually currently in the US is also being used for the same.
actually some centers in the US can't even afford the True Beam. Okay, they can afford, but
Yes,
for others, they
they
don't have the
can't.
True.
Some can't.
So we acquired our first true beam, and we started
Mm.
with what we call advanced techniques, 3D conformal radiotherapy. After
Yeah.
6 months, we upgraded, we went to IMRT,
Mm.
and after a year, we went to VMAT. VMAT is one of the top radiotherapy delivery techniques right now
Mm.
used. Why? good worldwide VMAT stock. So in 2022, we got two more true beams. So in total, we have three true beam linear accelerator machines that we
Wow.
are using for radiation therapy. And these, as I mentioned earlier, they are known for precision and accuracy. As we
Mm.
said, we want to get very high dose, but we don't want the normal tissues around to go beyond the tolerance, because the
Mm.
aim is to improve the quality of life of the patient.
Mm.
And right now, as I speak, there's an ongoing construction works for a bunker. You know where these equipment as sheltered. That room is
Mm.
called a bunker. So there's
Mm.
it's construction ongoing for bunker, and we are supposed to procure a SPECT and a PET
Mm.
machine. These help in diagnosis, and these are important in accuracy of diagnosis of the cancer and
Mm.
staging of the cancer. So
Mm.
that is something we're expecting within like 2 years from now to be completed and uh, to be functional. That will be very good achievement and an addition to. Now, recently we started using what we call we are we are using what we call image guided radiation therapy.
Mm.
Is also an advanced technique whereby before you treat, take an image to determine that where you want the radiation to go is where it will go.
Wow.
That is a good achievement. But and over
Wow.
recent now we are thinking of what we call we are going to what we call surface guided radiation therapy. It's also
Wow.
another defense technique. And
Mm.
we've recently started using what we call gating. There's what we call
Yes.
gating radiotherapy,
Yes. Mm.
whereby for tumors that are around the chest or within the lungs,
Mm.
uh, you follow their movement, because you are breathing. When
Yeah.
you take in a breath, the tumor goes to a different location. You breathe out, it goes to a
Yeah.
different. But you want to
Mm.
target it every time. So we
Mm.
started implementing. We got some experts from Egypt. They were here some like 5 months ago. We went through the
Mm.
processes, and now we are treating our breast cancer patients and lung cancer patients using what we call
Mm.
DIBH, deep
Mm.
inspiration, breath hold. That one tracks the tumor where it is. When it is in the right position, the radiation goes on. When it goes out of range, the radiation goes off automatically. We've treated a number of patients using that technique, and that helps reduce radiation on normal tissues, especially the heart.
Mm.
The heart is radiation, it is also a radiation sensitive organ. So those are some of the advances in radiation therapy that we have achieved of recent, and we hope to to have more advanced techniques. We are in the pipeline. We have SBRT, stereotactic.
Mm.
Stereotactic, you use a high dose, target a small area within where the tumor is, treat someone for 1 2 days, they go. So the machines we have currently, one of the Linux accelerators has the capabilities to do that. We are waiting for a little polish
Yeah.
among the human resource here and there, then we'll kick off. So anytime you hear that there's SBRT, not the word SBRT at the Uganda Cancer Institute, that will be another development.
Wow. That is very good news to hear. You see, these are some of the things that we don't hear about. You normally hear study stories coming from hospitals, but I'm telling you, after traveling to about 4 countries and being a nuclear medicine imaging expert, I can tell you when it comes to radiotherapy, Uganda should be among the top nations in the world when it comes to that. Maybe we just have not many centers, but I believe the one we have is actually giving Ugandans state of the art treatment when it comes to radiotherapy. And I want to appreciate our government of Uganda, Ministry of Health, the leadership of Uganda Cancer Institute, the leadership of Mulago Hospital. Thank you so much for allocating funds to that department, because unlike other diseases and sicknesses where we can go to private hospitals, when it comes to radiotherapy, private, public, rich and poor, we all have to go to Uganda Cancer Institute and Mulago Radiotherapy. And I wish all the diseases were like that. Maybe we would have actually more administrators actually put more money to that benefit all of us. Because when it comes to radiotherapy, you can't run to private centers. You will have to go to Uganda Cancer Institute. And I want also to thank all the employees and staff at Mulago Radiotherapy Department or Uganda Cancer Institute, but specifically the therapy department. Thank you so much. That's the only place that is going to work Monday to Sunday, day and night, on public holidays. They don't rest because they are making sure that they actually try to see as many patients as possible to make sure that patients receive their therapies in time. These are people that are supposed to be called heroes. These are heroes that don't receive national heroes, but they are serving the country. And again, thank you so much, Dr. Karim, for sacrificing your early morning hours to be with us. I believe the information you've shared with us has not only empowered us about radiotherapy alone, but we've also got to understand a lot of things that actually happen. I believe our patients, I believe if there is a patient that was waiting to actually undergo this screening and therapy, they have been calmed down, they have been informed, they know what to expect, they know some side effects, and actually they know exactly what to do. Dr. Karim, before you leave, would you send greetings to a few people, your department, fellow, your staff, your bosses, and also your family?
Yeah, for us old men, we usually have a long list of people to send greetings. Just say, whoever has had any impact in my life, thank you very much, and thanks for all the sacrifices you made. And also, would like to appreciate the Uganda Cancer Institute staff, despite the fact that the working conditions may not be the most appropriate. The staffing, well, this is common knowledge that the staffing is not enough, especially the radiotherapy
Yeah.
staff. Radiation therapists, the numbers are still so low. The remuneration, we won't talk about that, it's still not so nice. But these are people who are sacrificing. Actually, the department opens at 4 a.m. in the morning
Yeah.
and runs up to 5 p.m. In the evening or in the night, just
Yeah.
because the numbers, the staff, the staffing is not enough, so they tend to sacrifice through those long hours. So we appreciate what you are going through, and we encourage you to be patient and
Okay. Uh, okay. Yes, doctor. Are you finished?
yeah, I think then we also encourage people, as you said, to go for screening as early as possible. Don't run away from facts. If at all you are told that you have a condition, running away does not solve it. Come for treatment at the Uganda Cancer Institute. Yes, there are some costs incurred, but they are not that, they're not that unmanageable. So, and if for those who don't manage, there's also a window. You contact the healthcare team there. They will tell you how to go through that window. Generally, the services are available. Encourage people to come. Thank you very much.
Again, thank you so much, Mr. Karim, for being with us this morning. We wish you a lovely Sunday to you and your family and to everyone at Uganda Cancer Institute. Uh, Today marks the last Sunday where we've been talking about cancers. And I want to thank all of you that have tuned in large numbers to watch our episodes about cancers. I want to tell you that this is one of the most watched episodes ever since this page started. We started our first week with awareness on cervical cancer that was given by Barbara Ole from Lubaga Hospital. Then we had a discussion around prostate cancer that was given by Dr. Ankarubo Jonathan. And last Sunday, we had a discussion on breast cancer that was given by Dr. Mugabe Daniel. Today, we conclude our Cancer Awareness Month with the discussion from Mr. Karim, and he was taking us through radiotherapy. For all those cancers, one thing that is common is that when you're diagnosed, eventually you have to go for therapy. Like all of them I've said and shared, that the therapy will range from surgeries, chemo, radio, or hormonal, depending on the stage, on the size of the tumor, and then the locations of the tumor and other factors. One thing that is common, early screening and detection is one of the most sure way that is going to help oncologists, therapists to actually plan for your treatment journey. Like I said, this is a lonely, silent, painful, but a journey full of hope. I want to thank all of you that always tune in every Monday. I want to thank all of you that is subscribed to this channel. I want to thank all of you that actually take time to share these videos. Just like always, you go ahead to share all the other entertainment videos, the music, please share this video. You don't know someone who was diagnosed, but they are scared of going for radiotherapy because of the myth and misconception that Mr. Karim has cleared. Again, to every person going through this journey of radiotherapy, you're not alone. Let's support our family members. Let's escort them for these therapies. Let's provide for them financially. Remember, cancer is not a one-man's fight, but it's a community fight. Thank you so much, Mr. Karim, once again for sharing your deep knowledge and helping us understand radiotherapy and how it works in cancer treatment. Radiotherapy is not something to fear. It's one of the most powerful tools that we have to fight cancer safely and effectively. And to everyone that has watched in, thank you so much for being part of this vital conversation. Remember, early detection saves life, and understanding the treatment options like we've discussed today is the first step to hope and healing. Don't forget to share this. Don't forget to subscribe for more life-changing sessions on health and wellness. And until next time, stay informed, stay hopeful, and continue spreading the information about awareness of cancer screening and its management. Again, from me and everyone in my production team, marketing manager and the director, we wish you a lovely Sunday and may God bless you. Sign out. Bye.